Okay, ladies and gentlemen, thanks. I'd like to introduce you to our next speaker, Dr. Mark Schiller. Mark and I have known each other for over 20 years. Originally, we got together in the attempts to promote private independent practice in various ways and served on a bunch of boards together and doing that. Mark is a psychiatrist in San Francisco, has a private practice in San Francisco. And he's going to talk to us about PEER, P-E-E-R, transforming medication prescribing for depression, anxiety, ADHD, ADD, and he's the medical director of Mind Analytics. Mark's a board-certified psychiatrist. He attended medical school at the University of Chicago, the Pritzker School of Medicine, completed his residency at Yale, Department of Psychiatry, fellowship in services research at UCSF, Department of Psychiatry. Maintained a private practice while also serving as an associate counsel, clinical professor at UCSF, Department of Psychiatry. Since 2008, Dr. Schiller's continued expanding his private practice as the founder and medical director of Mind Therapeutic Clinic, a private multidisciplinary psychiatry clinic in San Francisco Bay Area. He's also continued his research activities at medical director at Mind Analytics. Dr. Schiller has numerous scientific and medical publications and articles dealing in part with the use of EEG and clinical evaluation of patients' treatment for mental health and substance abuse. It's very interesting, his EEG data on drugs and EEG data. Mark?
Okay, I guess you can hear me fine over here, so. Good, thank you, Tom. It's very nice to be here. It's nice to see Tom again. We haven't run into each other for a good 5 years or something at this point. And I'm happy to see you're keeping busy. So, I don't know if I have to read this off or something. I'll let you just read it. So I revised the presentation a little bit. I thought it'd be to make it a little bit more congenial for primary care physicians, which I think primarily is what you are. So I'm going to talk to you about by far the most exciting, innovative thing in psychiatry. I say that, of course, because I'm involved in it, but on the other hand, I probably wouldn't be involved in it if it weren't of some importance and exciting to me anyway. So basically what we're putting together, our technology is a way of deciding on a biological basis what type of medication a psychiatric patient would respond to. So I think you'd have to agree that if we did have a tool that would look at a patient's actual pathophysiology and use that to determine what psychiatric medication they should be on, that would be exciting to the field of psychiatry and also probably to primary care physicians who really prescribe the majority of psychotropic medications in this country. So let me explain the reason this works, or what, based on what the problem is. So I'm sure many of you have looked at psychiatrists and wonder, what it is we do, and it's a terribly qualitative field. We kind of guess at medications and do some psychotherapy on the side. So, why is psychiatry different, in essence, from other areas of medicine? Well, one of the reasons is that our diagnostic categories are not based on physiology. They're based on a bunch of psychiatrists sitting in a committee room and saying, if you have a number of these symptoms together, then you have depression, or you have obsessive compulsive disorder, or whatever it is. But again, it's just based on a phenomenologic description and a group of people in a committee room deciding how many of those descriptions you need to have a diagnosis. So one of the things, though, is our hypothesis that not everybody who has a similar symptom has the same underlying pathophysiology. And also the reverse is true, that not everybody who has actually the same underlying pathophysiology expresses that disorder symptomatically in the same way. Well, here's an example. This is essentially what we're doing in psychiatry. We're saying that, okay, you have some sort of symptoms, you're in distress. I'm sorry, actually on this side, on the whatever side that is, depending on where you're looking at from, this is the way the rest of medicine actually works. So we have symptoms. Somebody has chest pain, let's say. So what do you do if somebody has chest pain? We know that there can be myriad causes for chest pain. Something from as simple as some gastric distress to you're actually having a heart attack. So, I mean, you do look at the symptoms, you look at the, the pattern of symptoms, the severity of symptoms. Of course, you don't just disregard that, but at the same time, you're going to do a physical exam, you're going to do an EKG, you're going to get enzyme tests, you're going to do whatever else seems appropriate at the time. In essence, you're going to measure physiology. So then what do? Well, you give a medication appropriate to addressing the particular point of pathophysiology. You're not going to give somebody with a heart attack Mylanta. You're going to address the physiology however is appropriate. And then the other thing is that once you've given treatment, obviously you're going to look to see if symptoms have improved, but very often you're also looking to see if the physiologic parameters have improved as well. So we don't do that in psychiatry for the most part. What we do is we have a patient who has symptoms. I'm depressed. We give them a medication that's called an antidepressant. We know that antidepressants can be used for anxiety, OCD, PTSD, all sorts of different reasons, but we've just happened to call them antidepressants. And then what we do is we measure symptoms. We're not looking at the physiology, really. The difference, so basically, if we were going to use the psychiatric model to the rest of medicine, we'd be saying, okay, you have chest pain. We've just found out that for some people with chest pain, Mylanta does seem to help them. So now everybody who has chest pain, we give them anti-chest pain medication, which happens to be Mylanta, and see who gets better. We really need to move psychiatry to a physiologic basis. So what was developed here is the PEER, or Psychiatric EEG Evaluation Registry report. In the past, part of this was also called referenced EEG. So in some of our literature, you might also see it referred to as referenced EEG. So what is it? It's a technology that's based on an EEG. Now, most of you are, in medical school, saw EEGs used by neurologists, and for the most part, these these were analog versions of the EEG, and you're looking at the shape of the wave, and you are, deciding if somebody has seizure, basically, from that. What we can do, and I'll show you a little bit later, is we can just take the data, now that we can get a digital signal, apply computers to the EEG, and we can quantitatively analyze the signal and come up with something called the quantitative EEG. So in terms of the PEER, the treatment is then based upon observable, objective physiologic abnormalities. So symptoms are certainly taken into account. You're not going to disregard that entirely, but now you're going to have a physiologic basis for the treatment. Utility is not restricted just by the DSM diagnosis, and what I mean by that is a lot of patients in actual practice are mixes of diagnoses, or sometimes their actual diagnosis is not clear. We're not going to disregard what we know about DSM diagnoses, but if somebody doesn't have depression, but they really clearly show an indication for, let's say, a stimulant, we still may treat them with a stimulant. So this work is based on some assumptions. So again, we have something called the digital EEG or quantitative EEG, again, a little different from the traditional use by neurologists. And we know from other people's research that these digital EEGs are stable over a period of years. Some researchers looked at it for about a 5-year period of time. So if you do a resting EEG in the same way on an individual, they're essentially the same for a stable period of time. It's also based on the idea, and other people's research has shown, that medications have a predictable electrophysiologic effect on the EEG. And the idea is, to some extent, normalizing or heading in the direction of normalizing an EEG is going to lead to improvement in symptoms. So just as a quick reminder for people who haven't looked at an EEG since they were in medical school, and I only spent like 3 days in a neurology clinic, so I couldn't tell you any of this stuff after 3 days. You know, there's different waveforms based on frequency bands. So these are not entirely arbitrary distinctions. There's certain frequency bands that are found in certain states. So beta state is a higher frequency state, and it corresponds with an area of high alert. Alpha is a more relaxed state. When you're closing your eyes and listening to you know, some nice music, you're going to get some alpha relaxation waves. Theta waves tend to happen when you're drowsy. I kind of think of them as an inattention wave to some extent. Delta waves happen when you're in deep sleep or perhaps in a coma as well. Again, if you use mathematical transformations, you can analyze this data. You know, and so there's various ways in which this data can be used, and which is not specifically what I'm going to tell you about, but there's other ways of using quantitative EEG, which I use in my practice, but just to show you how this can kind of correspond to some clinical aspects. I mean, so this is quantitative EEG data, and then it can be transformed to provide a visual picture. This is a somewhat basic visual picture. But you can see that we can show in this individual that we have a preponderance of theta waves in certain parts of the brain, which can be of clinical import. And then, similarly, there's some ways of using the EEG that are more advanced and sophisticated that I find very interesting. And this is called LORETA, or low resonance tomographic assisted EEG. And so in something like this, what we're taking is an idealized MRI picture. So they took 300 normal people and averaged out their MRIs till you get this idealized picture. And then you can use physical properties of a gel-filled sphere, which the brain is essentially that, and you can actually calculate the origin of an electrical current and the magnitude of that current. And so we can do this, and this is the same patient that I showed you before, who had a preponderance of the theta waves. And so here we can see that using, you know, the software that can really calculate to about a centimeter of spatial resolution what's the origin of that excess of theta waves. In this case, it happens to be in the anterior cingulate cortex. And so we know that that's, or we know, I mean, there's a lot of research indicating that areas like the anterior cingulate cortex and other areas of the central basal ganglia are involved in ADHD, and not just attention, but emotional regulation issues, impulsivity, some of the other clinical symptoms that one gets with ADHD. And we know that in this case, we have a preponderance of theta waves or inattention waves, which actually correspond with hypometabolism in this area of the brain. And so this is a case where we can use EEG data to really act like a functional MRI and show some hypometabolism in these areas associated with attention deficit. So I do use this in my practice. Again, this is not specifically what I'm talking about with the peer report, but I I thought it was of interest to show you that there's really a clinical and research background behind a lot of the work we're doing. So what is reference to EEG or the peer report? So what we're doing, again, is we start off, let's say on a new patient. We are doing an EEG. We're doing a digital EEG and quantifying the data there. And what we're comparing this to is a normal database that exists out there. So from the mid-'80s on, a effort was established to gather a normal database. So there were thousands of patients, well, not patients actually, thousands of normals around the world actually, between men and women, and from ages 6 to 90, who were screened out for psychiatric and neurologic complaints. Their EEGs were taken, and then we were able to develop what is a good and large normal database. So in our case, if we take a patient, we are comparing them against this normal database, seeing how they differ, being asymptomatic psychiatric patients, how they differ to that normal database. And then we're analyzing them to what we call our treatment outcome database. So the real, I think, important aspect of the peer report is that over time, in a somewhat brute force method, we collected 10,000 EEGs, or over 10,000 EEGs at this point, in patients with psychiatric complaints. And then over the years, they've been treated with different medications, and their clinical outcomes have been recorded. So we have over 30,000 treatment outcome points of data. And so when we do the EEG on a new patient, we're comparing them to this treatment outcome database and saying, essentially, you look like 400 other people in the database, and it turns out 80% of them responded to Prozac, as an example. But we're not looking just at antidepressants, we're looking at a range of psychiatric medications. So this is just an example of sort of looking at the peer report in terms of our earlier assumptions. So these are 39 patients. Somehow the alignment went off here, but we have basically 17 different DSM-4 diagnoses at the time. Some of them are similar, some of them are mood disorders, but we have mood, attention, anxiety disorders mixed up in here. All of these patients had the same abnormality, specific abnormality on EEG, and they all responded to a similar medication.
Just to go back, not on psychiatric DSM, what are the 293s and the 300s? Are those? So if you look at, I just don't know what those DSM classifications are. I mean,
the 296s are all variations of mood disorders.
okay.
These are anxiety disorders. This is attention. Actually, this is eating disorder. This is, I'm sorry, I've moved to the DSM-5, so now I'm forgetting my DSM-4.
Right.
But there's a range of different diagnoses here.
Yeah, I was just wondering if it was in the same spectrum.
So, this is essentially how we gather the data to see how it works. So we take known responders and known non-responders. We look at the likelihood of response, and we look at the similarity to known non-responders. And basically, we graph all of this, and we look for the correlation. And so in terms of looking at it for a serotonin reuptake inhibitor, we looked at this particular patient and looked at the likelihood of response in comparison to these other patients. So it's really a statistical measure that we're using, and we do this on a new patient. We're doing it really to look at all of the different medications and see how they compare to responders and non-responders. And this is an example of what our new report looks like. So medication classes overall are the most important thing that we can comment on. You know, and that has to do with our statistical power. So, you know, we have over 30,000 data points, but, and that's enough to provide a lot of data, but of course, as we grow, as we add more and more statistical points, our statistical power will grow and our ability to comment on individual medications or even combinations of medications will grow. But at this point, certainly our most reliable measure is on a class measure, which is okay. As somebody who, really the founder of this technology, once stated, you know, if I can, even if I can't read the pictures on the wall in a dark room, if I can avoid the furniture and not stub my toe, that's still useful. And so to some extent, that's what we're doing. So we're going to comment on a variety of different medications, different antidepressants, even some of the older ones like MAO inhibitors and tricyclics, which still have their use, stimulants, in which we're also going to be looking at Nuvigil, Provigil in there. We're looking at various anticonvulsants and mood stabilizers, benzos, atypical antipsychotics, and a few other assorted outliers. You know, and for the ease of use for many of our customers, our physician customers essentially, many of whom aren't also psychiatrists, we're just kind of saying in something akin to an antibiotic sensitivity report, you know, this is a likely medication, this is moderately likely and not as likely. And it is a statistical measure. So, you know, even if in this case, you know, somebody has, let's say, a 30% chance of responding, it doesn't mean that they're not going to respond, and, you know, because we know statistically some people in a 30% likelihood are going to respond, but that, you know, you're going to certainly, like in all of medicine, you're going to play the odds. Then, once we've looked at something like people in the likely category, so here we had these selective norepinephrine reuptake inhibitors. I mean, it's somewhat easy because there's only two, well, there actually are now three in the in that category, which actually brings me to another point, is that, you know, as new medications come out, it takes us a little time to add that new medication to the database. And so we have now duloxetine or Cymbalta, venlafaxine or Effexor. Now we have Fetzima as another SNRI, but we haven't been able to add that to the database yet. Anyway, there's a relative ranking for those medications. We have Effexor seems to be somewhat more likely to work than Cymbalta. In some cases, that relative ranking seems to be somewhat important, but, because there's a great difference between the two, and some it's not that big a difference, and so you're going to just choose based on clinical means for some as well. Yes?
And this result is just for one patient, right?
Yes, this is we're looking at the report on one patient right now. In the moderately likely category, this patient has a lot of options, and so, you know, we can get into the details of how one would read the report and decide on medications, but you can see that we can comment on a number of different individual medications there. So hopefully, from what I've said, what I'm saying makes some theoretical sense to you, that it's kind of hitting home a little bit, you know, how psychiatry in many ways is differing from the rest of medicine, and that this is an interesting approach. Of course, ultimately, the question is, does it work? I've been involved for 15 years or so in the research, so hopefully I haven't wasted my time, and it does work, and I hope to show you some examples of why that is the case. So, one of the things I think that also gives us some confidence in what we're doing specifically is that there's a lot of other research on EEGs and their use in terms of medication. So, you know, over 100 clinical studies are reported on the use of EEG in relationship to medication effects and predicting which medication to use. Two of them that I think are particularly noteworthy is the fact that a form of an EEG test, which looks at really the preponderance of theta waves in somebody's EEG, has been approved by the FDA to diagnose ADHD. So, and that's in children, and it's not to be used exclusively. You're supposed to also use clinical information as well, but it's an adjunctive diagnostic measure. So even the FDA has seen that there is a use for EEG in this field. Another bit of research that I think is very interesting is work done by Ian Cook and Ian Leuchter at UCLA in their psychiatry department. And so they were able to develop a variable, really a statistic that kind of combines aspects of the EEG, and they call it accordance. And so their work demonstrates that if you were to do an EEG and look at the accordance measure a week after starting an antidepressant, they can tell you whether or not the patient is actually going to respond to that antidepressant. So there was a number of studies done on this, and it's statistically proven that there is a difference when you use this measure. I don't think clinically it's as useful as it might be in terms of the effect size and just the utility of having already started somebody on an antidepressant, and then not just giving it a full shot since you've started it, but maybe changing an antidepressant only a week after starting it. Nevertheless, I think it does provide us with some good support that EEGs are useful and can be used for medication work. This is some of the evidence supporting the specific technology I'm talking about, the Peer report, which I think is more useful, for instance, than the accordance measure, because we're looking before you start a medication, and we're looking at a range of medications, not just antidepressants. So I think it's clearly more useful. So there's been technological reviews and assessments that, to a large extent, have said that, well, psychiatry, the evidence for a lot of what we do in psychiatry isn't actually that great to start with, and that in comparing the evidence of Peer report, we actually do quite well. But then we have a number of studies, and I'm going to go through two in particular, but we've done studies at Walter Reed with military, a large multi-site study at Harvard, Stanford, and a few other sites, some pilot work at Stanford, and other studies, and quite a lot of sort of open label trials in eating disorders and other areas. So I'm going to focus on two studies. This one was the large multi-site study at Harvard and Stanford and Cornell in some places. And so what we did in this case is we had a randomized, controlled, blinded study, and we half of the people in the study, everybody had to have treatment-resistant depression. So even though our technology could comment on somebody with a host of different psychiatric complaints and could be diagnosed in different ways, of course, people still tend to think in the DSM boxes, and so in this particular case, we restricted the study sample to people with treatment-resistant depression. So half of the people in the study were in the control group. They were all treated according to a protocol from the STAR-D study. I don't know if you may know this or not, but it's stepwise treatment of resistant depression study. Quite large study, I think about 6,000 people in the study looked at over a lengthy period of time, I think about 5 years. And so basically they were categorized in sort of different steps of depression treatment, and then if you're at such and such step, then you would have 3 options from there, and it was analyzing basically, can we look at what should be done at these different steps of treatment-resistant depression treatment and which of those options may be the best. In the end, what it does is categorize the likelihood of response pretty well in each of these steps. It didn't show that you could really pick out different treatments in those steps as being better than the other. And you know, what's somewhat depressing, I guess, pun intended, is to find out that, you know, the chances of response at the different steps of treatment for treatment-resistant depression are not that good. So you have, you know, at certain levels, you have a 15% chance now of getting better. Now, it's, of course, this was at a point in time. It didn't have Abilify in there. It didn't use ECT, or for instance, in the study. But, you know, overall, you could, over many steps, you could get about a 2/3 response rate. But at any particular step, your odds weren't that good of treatment response. And the experimental group here was guided by peer, and it wasn't restricted to using just an antidepressant. We could use whatever medication was suggested. And so our main measure was the QIDS scale, which is a depression inventory scale. And what you saw is that the QIDS score declines more for the experimental group than the control group, and it did so, of course, in a clear, statistically significant manner. What's also interesting is that the differentiation really could be determined after about 2 weeks. And so it's also showing you that the time frame of treatment and treatment response is really quicker if you're using the EEG guidance. And then the Q-less-Q was a secondary measure here. This is a quality of life scale. And in this case, the higher numbers are better, and so the EEG-guided treatment was superior to the control group, rather, and it was statistically significant. And again, you could see a differentiation in as little as 2 weeks. This is looking at just some a variety of measures, and we're looking at percent improvement over the control. And using the main measure, you'll see that the EEG-guided group had 65% more frequent response than the control group, and then about a 35% greater remission rate. And remission rate was looking at, I believe, greater than 50% decline in the depression scales. So then, we are in the middle of a study that was done that's being done at Walter Reed, and this is interim data, and this is interim data on 150 patients. Essentially, we used a similar type of protocol. So we had a randomized, controlled, blinded study here. Half of the group were treated by the military physicians as they wanted to. They were all, again, diagnosed with depression. They could have secondary diagnoses of PTSD or whatever, but they all had to have meet criteria for depression. And so the control group was treated based on standard of care in the military hospital, and the other group was guided by EEGs. And in this case, we restricted the use of the report to FDA-approved indications based on diagnosis. So, you know, you couldn't use a stimulant, for instance, unless you also had a diagnosis of ADHD in this particular study, which in some ways I think hamstrung us, and so I think it's even more impressive that we have good results from this study. So we showed a 144% greater improvement in the QIDS depression scores. We had a 75% greater improvement you know, in a suicidal ideation measure, and 139% greater improvement in a trauma scale here. All I think of which is quite impressive. you know, some of the other aspects that are very much of interest here is that the soldiers that were in the experimental group stayed in treatment much longer than those who were treated without the benefit of the EEG guidance. So obviously the assumption is that they weren't getting better. And they said, well, forget this, I'm not coming to my next appointments. And, you know, and I think that's very impressive, and that also shows, it kind of goes to another statistic that we look at in our different studies, which is looking at the time frame to significant medical improvement, which is much quicker using the EEG guidance. And so I think, you know, as practicing clinicians, this is really important for us. If you don't get somebody better quickly, they do leave treatment. They sometimes become suicidal, something bad happens to them, and also they're suffering. So, you know, they may be suffering for months longer, perhaps even years longer, unless you get them on the right treatment. And so if you have a technology that can get them on the right treatment more quickly, you know, that's terrific. I thought I had another slide in there. But anyway, we're doing a number of other studies, and I would also point out that we've done studies outside of treatment-resistant depression that, again, are looking at things like eating disorders or attention deficit or other diagnostic categories, or at least symptom presentations. And so I would just make sure that you take home the point that we're not just looking at people with treatment-resistant depression, and we're not just treating with depression. We're looking at a range of psychiatric problems and a range of psychiatric medications. So I think maybe the best thing at this point, rather than go through other studies which show similar types of results, is just to open everything up to questions.
Thanks, Mark. That was very interesting. I have a couple of questions. Maybe I take the privilege of starting with a couple of questions. One is, how does this data compare to the genetic data on DNA testing to get similar information, like from companies like GeneSight and Mental Health DNA Insight, who use genetic testing to come up with the same idea? What's the best drug for somebody with a particular psychiatric disease? And can they be used in conjunction with each other? And does it add anything to add one to the other, or vice versa?
Yeah, you know, I mean, of course, the genomic testing is of great interest, and I think in a sense, what we're looking at here is phenomic data. You know, that we think that there is a genetic relationship between a lot of the presentations of on the EEG, and that these kind of describe phenomes. The genomic data is, you know, great piece of research, and I think there are some clinical uses for that data, and you know, and we do want to look at how this combines with a full picture with genomic data. But by itself, I think the clinical evidence isn't really there for the use of genomic data as sort of a prospective tool to decide what medications to be on. And I think there's a variety of different reviews of the strength of that data, and I don't think, you know, I would pick, you know, that there's somebody who needs an antidepressant and which antidepressant based on that data. I think there are times where I will use it is that they haven't responded to an antidepressant, and sometimes I'm not really sure why that is. So I might look to see whether they're just poor metabolizers or really high metabolizers of a particular medication. But you're looking at a relatively small percentage of people who really are in that category, and so overall I don't use that data to decide on medications. I think it's trendy, and I think it's something that will be used more and more, hopefully in conjunction with this, but I don't know, for me, it's not ready for prime time.
This is more useful. The other thing is, you're in San Francisco doing all this analysis, and we're all over the country. Can you get a digital EEG in Kansas City and send it to you? Are you working on that kind of?
Yes. You know, we've set up some specific centers in San Francisco, in LA, where we can get the EEG done for you. But in other parts of the country, excuse me, we will try to arrange or help you to get an EEG done. It's really not that hard. I mean, you just need, you know, to use what's called the International 1020 system of lead placement. You just have to do it in a similar routine fashion in order to gather the data. Once you have the data, you just send it to us. And so essentially, we're acting like a laboratory. You just send us the data, we'll analyze it, it sends you back a report. So, you know, it can be arranged almost anywhere. And certainly some physicians have just decided, well, this is of enough use, I'm gonna go get an EEG machine, which, you know, can cost anywhere from, I don't know, $10,000 to $20,000. Train somebody or have an EEG technician gather the data for me, and then I'm doing enough where it makes some sense to do it in my own office. But we can certainly find other places to do it for you.
So like if you just got an EEG at the local hospital and sent the data to you, would that work, or do you need something different than that?
If they do it in the manner in which we need the data, yes, you can do it.
Questions? Yeah, go ahead first.
You know, looking at the, you know, primary care with the diabetes being independently associated with depression and also early onset of, you know, dementias and Parkinson's and other neurodegenerative conditions. Do you see any different patterns in those individuals as opposed to just presenting with depression?
Well, you know, I mean, that's always a difficult question. I mean, people do get depressed for physical reasons. I mean, we know, of course, of maybe the best example of pancreatic cancer. But, you know, and there's certainly an overlap when you're seeing people who have medical illness. Many of them, though, had depression prior to their illness becoming, you know, clinically worse. And so you think that a lot of those patients probably did have depression before, you know, the organic illness, if you will. So overall, in my practice, it's not clear. You know, I can't differentiate that well. I mean, there's some people that are in the midst of cancer or something, and I'm certainly assuming that their depression is largely, you know, resulting from that. But, you know, in many cases, I'll still give the testing a try. I mean, and as we know, there are studies just looking at treatment of depression in people with cancer or people after having a stroke or something. And it would, you know, I think overall the evidence is that it's best to try to be aggressive with treatment of the mental illness, even in the midst of a medical illness.
The cost of the EEG is pretty well known to everybody, but for the cost of the peer report or any additional cost with that, what's that usually run for the patient?
Well, you know, the way it's done is this is ordered by a physician. They send the data to Mind Analytics. Mind Analytics sends back a report. And at this point, what Mind Analytics charges for taking the data and analyzing it and sending out a report is $400. It's up to you to charge what you want to charge. You know, you could look at it as, you know, there are some other people doing diagnostic testing that can charge thousands and thousands of dollars for what they're doing. I don't do that. You know, I probably could, but I try to make it affordable for the patient. You know, and I would also say that, you know, patients can often get some insurance reimbursement for what they're doing too. So, I mean, at this point, you can't bill for a peer report per se, but you can bill rather for, you know, conventional EEG and, you know, other codes that are appropriate.
Why would insurance pay for an EEG for depression? I mean, what's the rationale there?
They just do.
No, they do. Okay.
Yeah, if you're a physician and you order an EEG.
Diagnosed with depression, and they'll pay for it? Oh.
Yeah, I mean, sometimes, you know, if you had any HMO or something, you know, perhaps you have to, you know, validate why you're doing an EEG. In the case of my patients who primarily have PPOs, I'm a physician, I'm ordering an EEG, and they will reimburse the patient for that.
But Medicare is paying?
You know, actually, I don't know. Medicare is paying, I think, right, George?
With that diagnosis?
Mental health parity went into effect, and it's a law that basically says if you're paying a neurologist, so that people do a test, and it's currently a scope of service. So any other doctor, it used to be they wouldn't pay for EEG, now they do. And the average payment for an EEG by Medicare is around $681 for 2 codes.
The difference in the technique, in other words, if you said there's a certain algorithm or a certain way that you attach the electrodes in your EEG versus how the hospital is doing standard EEG, correct?
Well, the most standard form of EEG is what we use, which is the International 1020 system.
Okay, international.
Sometimes if you're doing, for instance, a sleep test, you're not going to put on 20 leads. You might do a simplified array, but for the most part, I mean, anybody who knows an EEG, how to do an EEG knows a 1020 system.
Okay.
So, you know, from there you just need to do a few other minor things to get the testing done in a standardized fashion. So it's really not that hard.
I'm just wondering, how do you convey that to the person who's actually doing the test? In other words, I order an EEG at the hospital, and I said, oh, by the way, we need to do X, Y, and Z for the peer. So,
Well, basically Mind Analytics could talk to them.
so they have a conversation with Mind Analytics.
Yeah, and that's easy. And I'd say that also probably the majority, George is the CEO there, could tell me if I'm correct, but the majority of the testing that we're getting done around the country are not happening in hospitals so much as sort of with itinerant EEG technicians, because there's people, a lot of people using EEGs are using it for something called neurofeedback, and so there's people around the country who are using EEG as a sort of a treatment tool, and I won't get into that right now, but they, you know, are well trained in how to place the leads, and they can do it in the way that we need it to be done, and they can often just go to your office and have it done.
So approximately what percentage of psychiatrists are aware or are using this technology in their treatment algorithm for depression?
Well, we don't have a survey, but I can tell you it's a small percentage.
Smaller percentage, okay, thank you.
That will change, but right now it's a small percentage.
Okay, thank you, Mark. Great
Okay,
talk.
thanks for having me.
Enjoyed it a lot. Good to see you again. Let's get together more. All right.